All right, let's dive into this. We're tackling those benign and malignant soft tissue and bone tumors of the hand.
Yeah, gotta know this stuff,
Right.
especially for those board exams coming up.
Definitely. And it's something you see a lot of, hand masses, I mean. Got to be on top of it.
Absolutely. You really need a good system for approaching these cases,
Mhm.
for diagnosis and management, of course.
So, where do we start?
Let's kick things off with benign soft tissue tumors, those bread and butter cases.
Sounds good. And I think the most common one we see got to be ganglion cysts, right?
You got it. Ganglion cysts, number one. And we're talking way more common in women, usually in their 20s, 30s, and 40s.
Yeah, that tracks. What's actually going on there? Inside, I mean.
Well, think mucoid degeneration. Basically, this gelatinous material building up in the connective tissue around the joints, the tendon sheaths.
Ah, okay. So is it like from an injury?
Sometimes, yeah, maybe one specific injury, but often it's more like repetitive strain, little things adding up over time.
Interesting. So how do these things usually show up? What do we see in the clinic?
Well, the pain can vary a lot, and the size might change over time, too.
Fluctuating.
Right. When you examine them, they're usually pretty movable, and they transilluminate. You shine a light through
Oh,
them.
yeah. And if it's connected to a tendon sheath, it moves with the tendon, right?
Most of the time, yeah. Except those coming from the volar retinaculum, those are a bit different.
Good to know. And x-rays, they help us out here.
X-rays are more for ruling things out, making sure there's nothing else going on. Bone problems or joint issues that could look like a soft tissue mass.
Makes sense. So if we were looking under a microscope, what would we see with a ganglion cyst?
You'd see these compressed collagen fibers, no synovial lining or epithelial cells, and the fluid inside has stuff like glucosamine, hyaluronic acid.
Ah, okay. So there are different types of these ganglion cysts, right?
Definitely. You got to know the subtypes.
Like, what are the main ones?
Okay, so the most common, hands down, dorsal carpal ganglion. Makes up like 70% of cases. It pops up over the scapholunate ligament, usually between those third and fourth extensor compartments.
All right, dorsal carpal ganglion, got it. What else?
Then we have volar carpal ganglion. This one, it's actually the most common type in kids under 10. Interesting, huh?
Yeah. So does it, like, go away as they get older?
It can, but in adults, it's still around 15–20% of cases. Usually starts near the FCR tendon sheath. Could be the radiocarpal joint or the scaphotrapezial joint, too.
Okay. Important to remember, right next to the radial artery.
You got it. That's key.
Okay, so dorsal, volar, any others?
Yeah, got to know about those flexor tendon sheath ganglions, the volar retinacular ones. These guys hang out at the A1 pulley a lot, sometimes between the A1 and A2 pulleys.
And those are pretty small, right?
Yeah, tiny, like 3 to 8 millimeters. And here's the thing, they're attached to the tendon sheath itself.
So they don't move with the tendon.
Nope, they stay put. Direct injury to the sheath is usually the culprit. And sometimes you can actually treat these without surgery.
Really? How so?
Aspiration, steroid injections, even massage can help sometimes.
Wow, interesting. Anything else? I feel like there are more.
You're right, there are. Eucocysts, gotta know those.
Yeah.
They show up on the back of the distal phalanx, the P3,
Okay.
often connected to the extensor tendon there, or the DIP joint, maybe the capsule. And you might notice the nail's got this groove running down it.
Yeah, I've seen that. What kind of patient gets those?
Think older women. And usually it's tied to some degenerative changes in the DIP joint. The joint space narrows. You see osteophytes on X-ray.
Right.
The skin over these cysts can be super thin, easy to rupture.
Ouch.
Yeah, and when you operate, you got to take out those osteophytes too. Can't forget to check the other hand too. Might have a hidden cyst lurking there.
Good point. So that's mucocysts. What was the last one? Carpal boss, right?
Yeah, carpal boss. These are painful, bony feeling masses. You'll find them on the back of the hand, the base of the index, or middle metacarpal.
The IF and MF metacarpals.
Exactly. And they often go hand in hand with arthritis, literally. About 30% of the time, you'll find a ganglion cyst there too.
Wow.
And again, we're talking women. They're dominant hand, usually in their 30s and 40s.
Okay, so we've covered a bunch of these ganglion cysts. Now, how do we get rid of them?
Well, sometimes they just disappear on their own, especially in kids.
Makes sense.
Even in adults, they can regress.
So we don't always have to jump to surgery.
Not at all. You can try aspirating them, maybe inject some stuff in there too.
But if that doesn't work, or it's causing problems...
Surgery is the answer. You got to take out the whole cyst wall, the stalk too, and where it attaches to the joint capsule or tendon sheath.
All right, get it all out. Do we close up the capsule?
Don't have to, really.
Yeah.
And after surgery, patients can usually go back to work pretty quickly. If everything goes smoothly, that is.
Right. So no guarantees. Can these things come back?
Unfortunately, yeah. Recurrence rate's about average, 24%. Got to warn the patients about that.
Always good to be upfront about that. All right, moving on. What's next on our list?
Giant cell tumor of the tendon sheath. Number 2 in terms of frequency.
Okay. Giant cell tumor. So who gets these?
Usually a bit older crowd, 40s to 60s. And it's got another name you might hear. Pigmented villonodular synovitis. PVNS.
PVNS. Why is it called that?
Describes what it looks like. Pigmented, meaning there's color, nodules, so it's lumpy. And villonodular, that describes the synovium, the lining of the joint. It gets all...
Like finger-like projections.
Exactly. And these guys like to hang out in the thumb, index, and middle fingers.
Interesting. Is there like a specific cause?
Not always clear. Some patients remember an injury, but a lot of times it's a mystery. But one thing's for sure, these tumors can really mess with how your hand works.
That's got to be frustrating. What makes these different from ganglion cysts?
Well, they're stuck to the deeper tissues, and they can actually eat away at the bone underneath.
Wow. So they're more aggressive. What do they look like?
Often you'll see this mass under the skin, yellowish-brown color.
Okay. How do we diagnose it?
Sometimes we do a fine needle aspiration, take a little sample, and the biopsy tells the story. You'll see these different types of cells: fibroxanthoma, spindle cells, foam cells.
Got it. And we got to watch out for that bone erosion. Could even spread into the skin.
Right. So how do we treat these giant cell tumors?
Surgery.
You got it.
Me.
We try to take out the whole thing. But these are tricky. They like to come back.
Oh, no. So what do we do?
Got to be really careful taking it out. Get any little bits we find, those satellite lesions. Sometimes we have to operate again. And in really bad cases, well, you might have to fuse the joint, arthrodesis. Or in extremely rare situations, even amputation.
Wow.
Yeah. And sometimes we use radiation after surgery, especially if we couldn't get it all out or if it starts growing back.
Makes sense. Okay, what's the next type of tumor? Epidermal inclusion cysts. Those are next on the list. Third most common.
Right. And these are the ones we see on the palms, fingertips. Usually after someone's had a puncture wound.
Ah, so something gets embedded in there.
Exactly. Those epidermal cells get trapped in the dermis.
And it takes a while for them to show up, right?
Yeah, it could be months, even years before you notice it.
What do they feel like?
Firm. Round. Like a little ball. Usually they don't hurt. And inside, it's this mix of stuff. Protein, cholesterol, fat.
So it's like the body's trying to wall off this foreign material.
That's a good way to think about it. And just like those giant cell tumors, they can sometimes erode the bone underneath.
Oh, okay. So how do we get rid of them?
Surgery. You got to take the whole thing out, the whole cyst, the wall, everything.
To prevent it from coming back.
Exactly. And if you get it all, the chances of recurrence are pretty low.
Good to know. Okay, moving right along. Glomus tumors. Now, those are less common, right?
Yeah, glomus tumors are pretty rare, 1 to 2% of all hand tumors.
What are they exactly?
They're benign. Hamartomas, they're called. They come from the glomus apparatus, that structure that helps regulate your body temperature.
Okay. I vaguely remember that from med school.
It's basically this specialized connection between arteries and veins and arteriovenous anastomosis. And these tumors, they have a classic presentation. 3 things.
Okay, hit me.
Pain, really intense pain. And when you press on it, pinpoint tenderness, like they'll jump off the table.
Wow.
And the third thing is cold sensitivity. They really don't like the cold.
Okay, so pain, pinpoint tenderness, cold sensitivity. Got it. Where do we usually find these glomus tumors?
Most of the time, it's under the fingernail, subungual.
Makes sense.
And get this, sometimes people have multiple tumors. Could be up to 10 of them.
Really?
Yeah, and you might see the nail's got some ridges or a bluish-red discoloration.
Okay, but they're small, right?
Yeah, usually less than a centimeter.
So how do we see them?
Ultrasound can be helpful. You need a high-frequency transducer, though, an MRI. That shows it pretty clearly, too. High signal on T2 and STR.
Okay, and how do we treat them?
Got to take them out. Excise the whole thing through a sterile incision in the nail bed.
And if we get it all?
Recurrence is rare.
Good. Okay, I think we have one more in this category. Ulnar artery aneurysms.
Ah, yes. Those are the ones we see in people who use their hands a lot. Carpenters, laborers.
Hypothenar hammer syndrome.
Exactly. All that pounding can take a toll on the ulnar artery. Mostly men get this, by the way.
So it's from repeated trauma.
Yeah. All that force near the artery, it can damage the vessel wall, and eventually you get an aneurysm.
Okay. How do they present?
Well, you might feel a pulsatile mass. It throbs. And sometimes they have symptoms of ischemia in the fingers. or even emboli,
Blockages.
right? And you can check for Tinel's sign over the ulnar nerve and do Allen's test to see how the blood's flowing through the hand.
Right, see if that palmar arch is working properly.
Yep. And the gold standard for diagnosis is an arteriogram.
So how do we fix these aneurysms?
Surgery. You have to take it out and tie off the artery. Ligate it. Sometimes, if the collateral circulation isn't great, you might need to use a vein graft to bypass the area.
Makes sense. And if there are emboli?
Then we might try to break them up.
Yeah.
Do some thrombolysis.
Okay. And these don't usually come back, right?
No. Recurrence is pretty rare if you do the surgery right, that is.
All right, good. So that covers the main benign soft tissue tumors. Now let's move on to those pesky peripheral nerve tumors.
Okay, so peripheral nerve tumors. Not as common as those other guys, but still got to be on your radar.
Right, around 1 to 5% of all hand tumors.
Yep. And remember, these guys come from Schwann cells. Those are the cells that wrap around the nerves. CT scans and MRI are your friends here. Help us figure out what's going on.
Right. Imaging is key. And there are several types, right?
Absolutely. Got to know the different flavors.
Okay, let's hear.
All right, so the most common type, neurilomomas, also called schwannomas.
Schwannoma. Easy to remember. What are those like?
They usually pop up in middle age. And a lot of times, they don't cause any symptoms. Grow nice and slow, encapsulated too.
So they're like contained?
Yep. And they don't actually invade the nerve fibers. They kind of push them aside.
Interesting.
Treatment, simple. Just enucleate them, take them right out.
And they don't come back often?
Nope. Recurrence is rare.
Good. Okay, so that's neurilomomas. What else?
Neurofibromas. Now, these are different. They grow right inside the nerve fiber.
Oh, wow. So they can cause problems.
Yep. You might see some numbness or tingling, paresthesias.
Right. And they show up early on, right?
Yeah, often before the age of 10. And sometimes you'll see this crazy thing. The affected finger or toe, it gets huge. Right. Localized gigantism.
Wow. That's wild.
Yeah.
Anything else special about these neurofibromas?
When you look at them under the microscope, they have these mast cells. That's a key feature.
Okay. And how do we treat them?
If we can, we take them out and try to fix the nerve. Primary repair.
Okay. And then there's neurofibromatosis, right?
Ah, yes. Neurofibromatosis type 1. That's one with all the neurofibromas and a bunch of other stuff too.
Von Recklinghausen's disease.
That's the one. It's genetic, autosomal dominant, so it runs in families.
What else do we see with this?
Well, they can get these tumors on the nerve that goes to the ear, acoustic neuromas, and sometimes on the optic nerve too. Optic gliomas, meningiomas too.
So lots of different types of nerve tumors.
Right. And sometimes they have this overgrowth of the limbs, like we were talking about, localized gigantism. And then there are these light brown spots on the skin, cafe au lait spots.
Right, I've seen those. And the big thing with neurofibromatosis is that these tumors can turn cancerous, right?
Yeah, unfortunately. They can become malignant, turn into sarcomas. It's not super common, but it does happen, like maybe 10, 15% of the time.
So we got to keep an eye on them. Speaking of malignant, let's talk about those malignant peripheral nerve sheath tumors.
Those are the scary ones. They're rare, thank goodness, but aggressive.
Only 2–3% of all malignant hand tumors.
Right. And they often show up in people with neurofibromatosis type 1.
So double trouble. What makes them so bad?
Well, they tend to grow into the surrounding tissues.
Yeah.
And they can spread to other parts of the body, metastasize.
Not good. And the survival rate?
Not great. High mortality rate.
So we need to catch them early.
Absolutely.
Okay.
Early diagnosis is key. And treatment. We got to be aggressive. Wide surgical excision. Sometimes amputation is necessary.
Right. To try and get it all. And lastly, we have those intraneural, non-neural tumors. What are those about?
So these are tumors that start inside the nerve, but they don't actually come from nerve cells. Weird, right?
Yeah, it is. What kind of tumors are we talking about?
Lipomas, hemangiomas, lipomatosis of nerve.
And those can cause that macrodactyly, right?
Yeah.
A big finger or toe.
Yep. Sometimes.
Yeah.
And thankfully, if we can remove them completely, they usually don't come back.
All right, good. So we've covered a ton of ground on benign tumors, ready to tackle the malignant ones.
Let's do it.
Okay, so first up, basal cell carcinoma, a common skin cancer, right?
Yep. Basal cell carcinoma. BCC for short. It's the second most common skin cancer we see on the hand.
But it doesn't make up a big percentage of BCCs overall, right?
No, just 2–3%.
Okay. Who gets BCC on their hands?
Usually middle-aged or older folks, people with light skin.
And it doesn't typically start from a pre-cancerous lesion, right?
Nope. It usually just pops up on its own. Often in areas where there are lots of hair follicles.
Okay. Are there different types of BCC?
Yeah, there are a few different subtypes. And you might see some unusual ones, like those on the palms or under the nails. Those are associated with a rare genetic condition called Gorlin syndrome.
Gorlin syndrome.
Right.
Got it. So how do we diagnose BCC?
Biopsy is the key.
Right. And these things grow slowly, right?
Yep, they're slow growers. You might see some skin atrophy, redness, little blood vessels, telangiectasia as they're called, and sometimes they ulcerate.
Ulcerate. Okay. And what about spreading?
They don't usually spread to other parts of the body, but they can be locally aggressive, grow into the surrounding tissues.
So we need to treat them.
Absolutely. The best treatment is to cut it out. Surgical excision with clear margins. Or Mohs surgery. That's where they take a little bit at a time and look at it under a microscope, make sure they got it all.
Right. Mohs surgery, for those tough cases, what if surgery isn't an option?
Well, there's some other things we can try. Electrodesiccation and curettage. Cryosurgery, laser therapy, and sometimes we use medications, things like interferon, chemo, or radiation.
Yeah. So lots of options, but some BCCs are more likely to come back than others, right?
Yeah, the bigger ones, the ones that have grown into the surrounding tissues,
Yeah.
the ones with poorly defined borders. And some types like sclerosing or morphic BCC, they're more aggressive.
More likely to recur. Good to know.
Yeah.
Okay, let's move on to the next one. Squamous cell carcinoma, SCC, the most common malignant skin cancer of the hand.
Right, SCC. And it's also the most common malignancy of the nail bed.
Wow. So where do we usually see these?
Often on the back of the hand, and it tends to affect older folks, mostly men.
Okay. What causes SCC?
Well, it comes from the squamous cell layer of the skin. And a lot of times, it starts in areas that have been damaged by the sun, or from a precancerous condition like actinic keratosis.
Right, actinic keratosis, those scaly patches.
Exactly. And it can also develop in chronic scars or ulcers. Marjolins ulcers, they're called.
Interesting. Marjolins ulcer. So how do these SCCs look?
Tricky thing is, they can look really different. Sometimes they're smooth, sometimes they're warty looking. Could be bumpy, could be an ulcer.
So we need to biopsy.
Absolutely. Biopsy is essential. And we got to be on high alert with these SCCs on the hand, especially those in the web spaces between the fingers.
Why is that?
They have a higher chance of spreading to other parts of the body. Metastasis.
Okay, so we need to take them seriously. How do we treat them?
Same as BCC. Wide local excision or Mohs surgery.
To get those clear margins.
Yep. And for high-grade SCCs, or those that look suspicious, we might do a sentinel node biopsy. That's where we inject a dye and see which lymph nodes it drains to. Gives us an idea if it's spreading.
Right. Sentinel node biopsy. And for the more superficial lesions.
We can try some of those other techniques we talked about. Electrodesiccation and curettage, cryosurgery. And there's some medications we can use too. Topical 5-fluorouracil, systemic chemo, radiation.
Okay, so lots of tools in the toolbox. And what about recurrence?
That depends on a few things. How differentiated the tumor is, how deep it's grown, and if it's invaded the nerves.
Yeah.
Perineural invasion.
Okay, so those poorly differentiated ones, the ones that have invaded the nerves, those are the ones we got to watch out for.
Exactly.
All right, moving on. Melanoma. Now that's a serious skin cancer.
Melanoma. Yeah, it's the big one. And the hand gets its fair share. 10 to 20% of all melanomas pop up on the hand.
Really? That's more than I would have thought. Where do they usually show up?
Often on the palm or under the nail. Subungual melanoma.
Okay. And what are the risk factors?
Sun exposure is a big one. And there's a genetic condition called dysplastic nevus syndrome. That's where people have lots of atypical moles. Increases their risk.
Dysplastic nevus syndrome.
Got it.
Yeah.
So are there different types of melanoma?
Yep. There's superficial spreading melanoma, nodular melanoma, acral lentiginous melanoma. That one's common on the hands and feet. And lentigo maligna.
Okay, so we got to biopsy these, right?
Absolutely. Biopsy is key. And whenever we can, we try to take out the whole thing. Excisional biopsy.
And what do we look for under the microscope?
The most important thing is how deep it's gone. The Breslow thickness. That tells us the prognosis.
The Breslow thickness. Okay, so how do we treat melanoma?
Surgery. Wide local excision. And sometimes we have to amputate. Take off the finger or toe.
Wow. Is that always necessary?
Not always.
Yeah.
But sometimes it's the best way to get it all.
Right. And what about the lymph nodes?
That's a tough one. We might take out some lymph nodes in the area, regional lymphadenectomy, or we might do a sentinel node biopsy. But there's some debate about whether that's necessary for hand melanomas.
Right, controversial. So basically, we treat it based on how deep it is.
That's the main thing. The deeper it is, the more aggressive we have to be. Makes sense. All right, let's tackle the last one. Soft tissue sarcomas.
Okay, soft tissue sarcomas. These are less common in the hand, but they can be really nasty.
Right. Uncommon, but we still need to know about them. Who gets these?
They can happen at any age, but they tend to affect younger people more often than some of those other cancers we talked about. And they come from mesenchymal tissues, the stuff that makes up our connective tissues, muscles, bones.
Okay, so what causes them?
Not always clear. But we know that radiation exposure can increase the risk, and certain herbicides. And there were some genetic syndromes that make people more susceptible, things like neurofibromatosis type 1 and Life-Fermini syndrome.
Right. So those are the red flags. What do they look like?
They often present as this painless lump that keeps growing. Sometimes they can even feel like a ganglion cyst, which can be tricky.
Ah, yeah. Mimicking those benign tumors, so we got to be careful.
Absolutely. And plain x-rays can sometimes give us a clue. You might see some calcification or areas that look like fat, or even signs that the bone is involved.
Okay, but what's the best way to see them?
MRI, that's the gold standard for seeing the extent of the tumor, helps us plan the surgery.
Right, MRI for surgical planning. And we always need a biopsy, right?
Always. We got to know what we're dealing with. And when we take it out, we got to make sure we get that biopsy tract too, all in one piece. And block resection.
Right, to prevent those tumor cells from spreading. And these things can come back, right?
Unfortunately, yes. Local recurrence is a big concern. And they can also spread to other parts of the body. Metastasis.
Usually to the lungs, right?
Right. Lungs are the most common site.
Hmm.
But it can spread to the bones, lymph nodes, other places too.
Okay, so we got to be aggressive. What are the different types of soft tissue sarcomas?
Well, there are a lot. But here are a few of the key ones. Epithelioid sarcoma. That's the most common subtype in the hand. And it can recur locally and spread to lymph nodes.
Okay. Epithelioid sarcoma. Got it. What else?
Undifferentiated pleomorphic sarcoma. That one's a mouthful. It can look different in different people, and it tends to spread through the bloodstream.
All right. Undifferentiated pleomorphic sarcoma. Check. What's next?
Alveolar rhabdomyosarcoma. That one's really bad. It's highly malignant. It can grow really fast, especially in the palms of children. Prognosis is not good.
Alveolar rhabdomyosarcoma. Okay. That one's scary. What else?
Synovial sarcoma. This one likes to hang out near joints, tendons, tendon sheaths, bursae, and it can show up on x-rays as a calcified mass. Spreads easily, especially to lymph nodes.
Synovial sarcoma. Okay. Anything else?
Fibrosarcoma. That one usually starts deep in the tissues, subcutaneous tissue, fascia, muscle, and it likes to spread through the bloodstream.
Fibrosarcoma. Got it.
Then there's clear cell sarcoma. It's not as common. It grows slowly. But it's attached to the tendons, fascia, those kinds of structures.
Yeah.
And it has a high rate of local recurrence. We often have to use a combination of treatments for this one. Surgery, lymph node dissection, radiation, chemo.
Clear cell sarcoma. Multimodal treatment. Okay. Anything else?
Last one. Kaposi's sarcoma. We see this one more often in people in their 40s and 50s, mostly men. And it's associated with AIDS. It shows up as these dark blue or purple spots or patches, can vary in size. And the prognosis depends on how fast it's growing and how much it's spread. Treatments include radiation and chemo.
Kaposi's sarcoma. Okay.
Yeah.
So lots of different types of soft tissue sarcomas. And they can be tough to treat.
Yeah, they can be. The main thing is to get them out completely. Wide surgical excision with clear margins. And we often add radiation or chemo to the mix to try and prevent recurrence and metastasis.
Multimodal treatment again. And what's the overall survival rate like?
If we catch it early and treat it aggressively, the 5-year survival rate is around 65–70%.
Okay. Not great, but not terrible. So early diagnosis is key.
Absolutely.
All right, let's shift gears and talk about those benign bone tumors, starting with enchondroma, the most common one, right?
Yep. And chondroma. Number one, it's basically a lump of cartilage inside the bone.
And it often shows up on x-rays, right?
Oh, yeah. Classic appearance. Well-defined, round, kind of bubbly looking, with these little flecks of calcium inside.
Okay, so we can often diagnose it with an x-ray. What about symptoms?
Sometimes they don't cause any symptoms. We just find them by accident.
Okay. So they can be silent, but they can also cause pain, right?
Yeah, especially if the bone breaks. Pathologic fracture.
Right. The tumor weakens the bone. And where do these enchondromas like to hang out?
They like the long bones, the phalanges, the metacarpals, those tubular bones.
Makes sense. So how do we treat them?
If they're not causing any problems, we just watch them. Take x-rays every now and then to make sure they're not growing.
Okay. So watchful waiting. But if they do cause problems, we need to do something.
Right. And usually that means surgery. We scrape out the tumor, curettage, and then we might fill the space with a bone graft.
To help the bone heal.
Exactly. And here's a fun fact. You always got to fix that fracture first, if there is one.
Yeah.
Let it heal up before you go digging around in there.
Good point. Don't want to mess things up. So that's enchondroma. What about those rare cases with multiple enchondromas?